All right, so Jill Borowski couldn't be here today, so she just wanted me to introduce the speaker. So we have Andrew Evans from the Department of Health, who's going to talk to us about, looks like AIDS.
Good morning, everyone. Like I said, this is my third time doing the talk. I did two as the grand rounds, two of them last week. So what I'm going to talk about today, a lot of you are very familiar with me. I've spoken on other topics here. And my name is Andrew Evans. I'm from the Dutchess County Department of Behavioral and Community Health. We're no longer the Dutchess County Department of Health. We've recently merged with Mental IG. And we also have a new Commissioner of Health, Dr. Henry Kervin, as well. So Dr. Weaver retired as of January. So today I'm going to talk to you about the plan to end the AIDS epidemic in New York State. It's something you may or may not be familiar with, so I'm going to give you like a broad overview of the topic. Okay. Our outline is I'm going to give you some background. We're going to talk about what bending the curve means. We're going to talk about the three-point plan. We're going to talk about traditional HIV partner services. Then we're going to talk about expanded HIV partner services, and then we're going to talk about PrEP and PEP. Now, the background of why we're talking about this is like New York State has the most cases of people with HIV and AIDS in the country. And over the years, like for new HIV infections, nationally it's about 50,000 new cases each year. We've never actually seen anything to actually impact that number and have the number go down. So that's the premise of why this initiative was enacted. And I'll go into details of how they got to what the plan is. But this is the data. It's like it says, as of December 31st, 2013, 129,000 people either living with AIDS or HIV in New York State. Again, it leads the country. As you see, most of it is in New York City, the 5 boroughs.
Do you know the number in California?
I don't have the number in California. Probably not that far away from us, I would guess, but like we are number 1. So this is what I'm talking about was the premise of bending the curve. And, I have my pointer. Okay. So over the years, we have this line here is the blue line is the number of people diagnosed with AIDS. Pretty much it flipped up to about at a height about here, and then antiretrovirals came on the scene, and then you see a decline in the number of people diagnosed with AIDS. Also the same thing with death. Again, pretty much parallels AIDS, went down. Number of people newly diagnosed with HIV, we see, you know, even though like there's a blip in it, overall trend up. Okay? And right here, what I was talking about, this big space here, there's a widening gap between the new cases of HIV and the number of people that died of HIV/AIDS. And part of what's causing like a lot of back to like risky behavior is this whole thing here. It's like people are not seeing the yellow line anymore. People aren't seeing people die of the disease. You know, when it first started, it was very evident, and that maybe adjusted people's behavior as far as, you know, being promiscuous. But like I said, the gap has like gotten really huge.
Also, it's a narrowing in the gap in between death and AIDS. Also, you know, the presence of AIDS, not just the HIV infection.
Right.
I mean, maybe probably you guys are doing a good job, you know, with diagnosis, you know, and, you know, screening.
We are definitely finding more people, and I'm going to get into that specifically. So this is
people are getting infected because epidemiologically the curve is shooting up.
Yeah.
And that's from a Southern California view is a long way of doing it.
Exactly. I like that. And we're going to get into those specific things and why this plan has been enacted. See, I like you guys. Very lively audience already this morning. So this here is the model for this plan that we're going to talk about. It's like they've seen that the total number of people living with HIV/AIDS in New York right here, and then what they want to see. This is new infections. This is HIV/AIDS deaths, and they want to see what the plan starting here. They actually want to see the line of new HIV infections get below the number of HIV/AIDS deaths. In the history of the epidemic in the United States, it's never, ever been that way. And that is the goal of the plan. So, Governor Cuomo announced a plan to end the AIDS epidemic in New York State. There are 3 aspects of the plan. First is identifying persons with HIV who remain undiagnosed and get them linked to care. The second is finding the people who have HIV, but their viral load is not undetectable. That means that they're not in their taking their treatment regimen and finding those people and getting them linked back to care. And the third aspect, to allude to what you were talking about, we're still seeing a rise in new HIV diagnoses. So there are people taking lots of risk out there. So we actually have a tool to help target that population. The people who are HIV negative but are actually, for lack of a better word, they're actually out looking to get the infection, and, even though they're not knowing that they're doing that. They're taking a lot of risk, and all the behavior modification counseling, all the messages, they're just not getting it. They're just doing what they're doing.
How about those people who already have it? Somebody who's giving the infection.
Right, and there are people that that know they're infected and don't care. And I would say, in your experience, I don't know that it's as big a number as you think that is. I think
sometimes you can mix, hi, I'm Mary. Sometimes we can mix the message they don't care or they don't care about themselves enough to care. So that's part of the 3-pronged project. If we get people who are out of care into care, reduce their viral load, they're less likely to spread it. And then at that time, we do an intervention by getting all their partners and getting them on the PrEP. So at that way, by notifying their partners, they have a chance to remain serologist coordinated. Does that make sense?
No.
Oh.
It doesn't make sense to me that, we're decreasing viral loads, we're decreasing, we're increasing the lifespan of people with AIDS who are now living productive lives, and yet the rate has remained high, and the only reason that can occur is that people don't care. That there are people out there spreading AIDS who don't care. And I don't think we're attacking that aspect the way we should.
But I don't know what to say to that. I'm not disagreeing with you. There are definitely people out there that have it that, I don't know if don't care is the thing, but they just aren't taking precautions or they're putting people at risk.
Maybe it's the undiagnosed.
Yeah, and that's yeah. 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 So the first thing the first part of the plan is identifying persons with HIV who remain undiagnosed, part of what we're talking about here, and linking them to health care. And this here is I have a model here of like the 2 HIV partner services and expanded partner services. We're going to touch upon this one in the next group of slides, but traditional HIV partner services, we've been doing that since the beginning of the epidemic. We've been given charges, like people that are newly diagnosed, we did conduct interviews and try to elicit partners. I have to admit, in the beginning, it was not a very meaty program. It was almost sort of new, and not a lot of people were willing to talk about it. There was a lot of fear based on it. It wasn't as successful. But this Michelle Everling, who's not here, she's the public health advisor who does most of that work. And she targets, those, like I said, the new people in this chain of infection. She's looking, anybody that's newly diagnosed, we will contact that person and elicit who they're either having sex with, sharing meals with, and locate those people and get them notified. And what's helped us out immensely with this are 2 laws. In June 2000, HIV became officially reportable to the state, HIV/AIDS, and a tracking system. And this is when they really started to beef up traditional HIV partner services. We had so like you guys would have somebody newly diagnosed, fill out a form, go to the state, and the state would report it to us, and then we would locate people and get them notify them, find their partners and get those partners notified, tested, and links back to care. Over time, what we've done a little nuance to this. Instead of just depending on you to fill out the form and send it to the state, we actually have asked you guys to call us when you have a newly diagnosed positive, because we can actually come there and help you and talk to the person at that moment of diagnosis. We find that people, when they're initially diagnosed, are more willing to talk to us about who they're having sex with or sharing needles with. And part of it is like you give people time. One of the things that I find in my experience of doing this is a lot of people bounce it off me because they're trying to figure out in their head where this came from. And they think by having a dialogue with me that they might get an answer. We do not ever give that information away, but we have a very broad swath that we do there. But the other person in that dialogue, because I know if it happened to me, that would be the first thing. Where did this come from? How did they get it? So you're looking for ways. But we find that they're far more cooperative when they're and more motivated to work with us in the beginning. As time goes on, then that sort of starts to shut down. It's a little hard to get through. And then the second thing is that HIV opt-out reporting law that you guys here are all familiar with, of offering HIV screening to persons ages 13 to 64 years old. So both of these things are ways to look for the newly diagnosed. Yes?
I just got a couple comments, and maybe they're not politically correct, but
okay.
This offering it to everybody 13 to 64 is ridiculous on so many levels with children that you insult the parents. The kids are going to absolutely say no. And since insurance companies won't pay for the swab in your cheek, you end up having to draw it by vein. It is just something that's impossible to comply with in any rational fashion. And I don't know if there's any way around that, because sure, we ask everybody, but you ask it so the answer is no. And that's what happens, I think. Maybe it's just me, I don't know, I'm the only one willing to say it. But you ask it like you don't really want an HIV test, do you?
Actually, Mary and I were talking about that, and you're not being, actually, we've been down this road before with all of you guys when I initially came in and talked about this law with you guys, and we did remember that program we did a couple of years ago, we gave you guys the free tests?
Yeah, we did 10 times as many when I had those tests than when I don't.
Right. So, and it's definitely, I'm glad for the feedback. So, without that tool, you're having trouble complying, and
Well, there's a lot of issues that happen with that. If you draw blood, you don't get the results right away, which means you have to call the person back.
May I have your attention,
they're not
please?
in the office.
Trauma level 2, 5.
So,
Trauma level 2, 5.
You could get the wrong person to get the information. You got to give them information over the phone. So if it's positive, that's worst way to give information. With the swabs, it was easy. 15 minutes later, you have a result. You told the kid while they're in the room. Parents didn't even need to know that the test was done.
And don't forget the idiot New York State law that says the EOB has to say HIV testing. So it makes confidentiality 100% impossible in children. So I'm not going down that road when confidentiality is impossible. I refuse.
And it's usually older teenagers. It's usually, our 17, 18-year-olds who want the test, but they're still under their parents' care. And as soon as they find out that, this may be something that their parents will know about, they're not getting it done,
Well, again, I like that you speak up. This is good feedback for us, because I can bring this back and we can try to work on, like I said, it's doing the blood test as opposed to the swab test is one of the obstacles. I mean, we can try to maybe look for ways, to find a solution to this.
The other thing, too, is maybe we could work on some sort of signage that you could put up that if someone really wants a confidential test, what our free clinic hours are. These kids are all getting to the mall. I'm sure they can get to the clinic if they need to.
No. They don't do it.
They won't go?
But, someone's got to talk to the legislature. They wanted open laws for the HMO so they don't, screw the public, which they often do, by saying what you had done. But these laws are in direct conflict, completely opposite ends with this law.
And the other thing we could offer is free testing site at the mall. Well, we have a clinic and we do this outreach. But the other thing too is just for help for you, is if you do have someone that you know is positive, we can assist in doing the notification.
Yeah, so that is one way around it.
Go to their house, meeting with them, and or come to your office.
How do the parents not find out? That's the key.
That's their problem.
There's no confidentiality anywhere with HIV testing for children in New York. It's impossible. And without confidentiality, it isn't going to happen.
I understand from your side, but we test kids over the age of 14 every day in clinic.
Well, in your clinic.
Right.
But in my office, that is never going to happen.
The parents are usually with them. They come, they don't come by themselves.
Right.
You get one population that does that, we get a different one that doesn't.
Well, like just using that example, like in your clinic, like say a 15-year-old or something like that, they're just wandering in because they have a concern.
Mm-hmm. They come in, they want to be tested, or they've read somewhere that it's good to be tested, or a friend of theirs told them they suggest they be tested, and then they come into clinic and then we will test them. Everybody over the age of 14.
Well, I think those hours if we have them.
Sure, we'd love to give it to you.
Yeah.
And we can expand it.
Post it.
Sure.
Yeah.
And is that test then confidential?
Yes, our test is still correct, because it's a reproductive health.
So if it comes up positive, say on a 14-year-old.
Right.
So you, obviously the kid finds out, but what about the parents? Just hook them in with, how do they get their medications or?
Well, we start with care. With counseling, hopefully we can encourage them to have their parents aware, but there's workarounds for all of that. We have to give them, they have the right to their care, so that we work around it. We have different people that will work with us, that's because of the, what's it called, AID Act and all that stuff, we can get them, linked to care with providers.
So it doesn't cost the team anything to come to your clinic?
Correct, it's a free clinic at this point, yeah. They get screening. We can think about HIV as one thing, but we also, we give gonorrhea, chlamydia, syphilis testing. But we're all thinking sexual health. What about the kid who's now experimenting with steroids in the high school? Or what about the current person who are being forced by their partners through partner violence to have unprotected sex with him or his partners? There's a lot of different things besides the little kid who just wants to be screened. So we try to work around all those different areas of the clinic. One of the highest things we have for partner violence is, this is May, it's prom time. Some of these girls, I got me a date, I'm buying me a limo, let's have unprotected sex. So now they know that in their mind they want to be screened, so they'll come to our clinic. So we're just trying to have different workarounds for them.
If you want to bring back more feedback, here's a practical issue. For us, this is enormously stressful, time-intensive, uncompensated work. And the reality in the world is that isn't going to happen. Uncompensated work doesn't happen, which is why we have such problems with Medicaid and such problems with everything else, is that when they want us to do stuff out of the goodness of our hearts, there's a limit if you want to stay in business. And that's the problem. And I mean, I don't know, nobody ever says that in public, but that's the problem. Is that it's huge for us to spend all this time HIV counseling, none of it compensated. And then getting, for violating confidentiality, I mean, it's unbelievable the risk we take to do this. So nobody wants to do it.
But again, I appreciate your honesty because that helps us.
Right.
We can try and work on this, at least advocate for you.
We're going to a big meeting in New Rochelle next week, so
yeah.
we're very helpful.
Definitely. Like I said, that's why I appreciate you guys. It's like as much as I try to give you information, and we learn from you guys as well. That's why this dialogue is really important. It helps us craft something that hopefully we can come up with some answer, because it really helps us. So.
I honestly didn't even know you had a free clinic for this.
That's your $10 at work.
Is this, what is it called, the clinic?
It's called the STD clinic. It's a STD screening clinic. We hold it, right now we're up to 3 times a week. Our hours vary, but there's a number 486-3535. If they want to schedule an appointment, that's convenient for them. Or they could we have a walk-in clinic, and we'll be glad to send some posters.
If you have posters,
Posters would be great.
in the waiting room.
That way I don't have to mention in front of the parents saying, if the kid wants to go to STD clinic, there's one there.
Right.
Yeah, posters would be great.
Yeah, that's like,
Yeah, for sure.
Get excited, so you say, just if you have concern about your health, everybody can read them, doesn't mean you have to take them.
So we got 486-3535.
35 for an appointment. A clinic is at 29 North Hamilton Street, and right now it's every Tuesday and Thursday as a walk-in.
Are there clinics anywhere else besides that spot, or,
Not right now. We're trying to.
you know, like I'm currently in Pauling. No kid's going to drive 45 minutes to North Hamilton Street to get screened by himself,
Right.
unless he's an older teen and has a car, and unless these kids are not physicians to have cars.
Well, I believe there are other clinics in the region, like in Orange, Ulster, and Putnam, and the one in Putnam, I'll find out the hours and what their services are. They're probably very similar to us.
But if they're not a Putnam resident, can they do that?
Yes.
Because we're New York State funded.
It's all,
We cross all borders.
by law, every county has to have a free STD clinical services. STD services are required by law. Even Little Putnam County has to have their own clinic. Even if they were to contract it out with a provider, there has to be free service.
Well, I wonder if you can contact some of the surrounding counties, for those of us on the borders of surrounding counties.
Sure.
That they can also send posters that are more
Oh, that'd be great.
geographically relevant to where that office is located.
This is the kind of thing we need to hear. This is very helpful to us. So, yes.
Question about in terms of teenagers, what's the confidentiality agreement by law between both doctor, patient, and maybe clinic and patient in terms of parental?
Again, like I said,
Our clinic's completely confidential, we tell nobody. So the patient, because the child has a right to reproductive health, they can come to the clinic, they sign their own thing, they get screened, and they get treated.
And why 14 and above and not 11 and above?
There's some, I mean, I'm a really good nurse, but I'm a really lousy lawyer. I don't know the answer to that, but if that's the cutoff that we've been given, that's what we do. That's the law for us.
The law says 13.
Yeah, I think you come in at 13, you know, we would see you, but we try to stay at 14. We don't tell them. We don't tell people, they'll come in. We have other providers, you know, other people with specialties, shall we say. We were part of the state program.
So you would be allowed to, for instance, intermittently perhaps go into a school and offer free screening in patients, children in the high school or middle school do not need necessarily to advise parents that that's going on.
We don't go into schools. Those policies are received county policies. I've been going to Poughkeepsie High School and given a very good, strong STD lecture. I can't go to Weavertown. That's the school district themselves. We take the patient as an individual, and we don't go to school. We're not a school screening clinic.
But there
They
are,
come to us,
in New York State, though, and other states, there are school-based STD clinics. There are some, I don't remember where, but there are a couple in New York State. But in other places, like in Minnesota, they did a whole chlamydia initiative, and one of the key arms of that was school-based screening clinics, which would be effective for combating chlamydia.
If you look at the data, perhaps, those school-based districts have less incidence of HIV than the non-screen ones, than that's telling you about.
All right. Well, yes. Let's move on to ways to go. So again, traditional partner services, just quickly, it's voluntary and confidential. We assist the person, we assist them with notifying their partners, whether they want to do it themselves or they want us to do it or some combination, or even you guys, the medical providers, to do it. And again, we facilitate linkages of services, and these things may be handled different from state to state. North Carolina may do it a little bit differently than we do here in New York. And these things were formerly known as PNAP and CNAP, and now they just call it partner services. Moving along here. And this is like the continuum of it. It's like a client is HIV positive, we transition, we give them the options, we elicit partners, we make a referral and coaching, and then we do a summary, and then we locate the partners. I'm going to go into how we do that. Once we locate the partner, we notify, we do prevention counseling, we give a test decision, and then if we test them and link them to other services if needed, like we talked about things like domestic violence or rape or drug use, drug rehab, those other issues pop up as well while we're talking about this. And we work with the partners, and if that partner tests positive, then we start over again on the wheel here. So it's like a continuum. again, this part here, the investigative activity, is quite extensive. What we can do to find someone, we actually have lots of tools, new tools, because, you know, one of the things was like, just to give you an idea, I had a patient that was just diagnosed with syphilis recently, and I gave it to Michelle, who you saw on the slide, and it's amazing what you can find out about somebody on the internet right now. People aren't even aware that she can look at your Facebook profiles if they don't have a lock. She can able to see a picture of the person, well, the person had a spouse, you know, we find out all that stuff, and it helps us know something about it as well. We also have this federal database now that we can actually look for people. If we have just the first name and a phone number, we can actually put in something called accurate, and we can actually find like previous addresses, current addresses, where they went to school, quite extensive stuff. It's quite a little, from my perspective, a little frightening how much information that they actually have on us. We can only use it for STD investigation purposes, and if we were ever caught misusing it, we'd have the privilege taken away and be heavily fined for it. So just, you know, we're very careful and respectful with that information. Again, this is like the options for HIV partner services. This is the provider referral. It's traditional, where we would go out and do it. And I would just say that, like, not to pat ourselves on the back, but we have a lot of experience with this. So if you ever need this kind of service done, it's probably better to have us do it. Number one, it takes you out of the equation. We're not, like, linked to the case in any way. And we are trained in how to tell people this kind of stuff and how to get them services. And we're mobile. I mean, we can get in our car, go to their house, go to where they are. We have testing, the capability to test in the field when we see the person. So we're built for this. So definitely use us. Pick up the phone and call us. Patient referral, this is like where we coach the patient on how to notify partners. Some of them do not want us or you doing the notification. They want to do it themselves. That they have the option for HIV still. We strongly encourage them not to do this, because what do you think with this one will more likely happen? Do you think they're going to tell that person? Probably not. So we strongly discourage this one, but, you know, not to say that some don't tell their partners, but we find that it's not commonly done. Contract referral is like, I would like interview the person. They would like say, give me a week to tell them, but after a week, then you can do it. So it's sort of a fail-safe. If they just chicken out, then at least know that the notification will occur, but we'll give them time to do it. Third party, that would be you guys notifying the partner. And dual referral is they would do it together. I've done these a couple at clinic is a common place that I would do this. It's like somebody tests HIV positive, their partner is out in the waiting room, and they want to notify the person right then and there. They want to do it together with me in the room. So those are the options we have for HIV partner services referrals. Elicitation, just so you know, we are like detectives. I can just tell you that I've had descriptions of a person and a place that they frequented, and I've been able to find the person. It's really quite unbelievable what we go through to find someone. And I'm not going to get into specifics because I never want to breach anyone's confidentiality, but there are ways to find people, and we are very, very, very good at this. It's like, this is just, you know, it's like, I never knew there was such a job until I started doing this, but like, but again, it's like, one of the things is like the internet. I think a lot of young people don't really realize that they think that when they're on Facebook and stuff that nobody in the world can find this stuff. You know, it's really quite easy to get in and find out a lot about people and locate them. So I've actually found, like, based on one of the places I will say is this is one place that we try to avoid as a last alternative. Because I would tell you, of all the places where I go to find someone, if I show up there, probably I get the most heated reaction. Why are you at my job? Okay, but if I have no other option, then that's where I'll go. But again, I can tell you in all my years of doing this, 27 almost, never breached anyone's confidentiality. And hope to end my career not breaching anyone's confidentiality. Again, this is just for HIV, we go back a year. We can go back further for partner elicitation, but we focus on the last year. And again, we're looking, this is the index patient. We look for whether they have children, internet partners, needle sharing partners, anonymous partners. Like I said, you would think, how can I find an anonymous person that they met like in a bookstore? But you can actually locate those people, okay? Social context and lifetime sex partners. So this is what we focused in on when we're conducting this interview with the client. And we're, because a lot of times maybe with you guys, you're probably just focused in on the immediate one step out. We're thinking of a whole network of people that are involved in this, in their risk-taking behavior. The second linked part of the governor's plan is linking and retaining persons diagnosed with HIV back into care. It's also known as expanded partner services. Okay. And this is like the background of her expanded partner services is a national HIV strategy that was enacted. And they were looking for working together of the three organizations, state and local health departments, community-based organizations, and health centers and medical providers. That's where our HIV patients are, and looking for a way to find HIV/AIDS diagnosed and get them back into care. There's been studies done that if we can get the viral load, the community viral load, to allude some back to you, but if we can get that viral load where it's undetectable, like greater than 90 to 95% of the population in the community, then that number, that decline in new cases, we can actually see. And that's the whole crux of this aspect of it, is to find those people, get the viral load undetectable. You're creating almost like a vaccine herd immunity around that. Even though people are taking risk behavior, they're less likely to get HIV. Not to say they're not going to get other STDs, but at least HIV is more likely off the table. And that is how the premise of starting to maybe get a decline in new HIV diagnoses. Again, you are going to have, not to point, but your point about people that are, you're going to have those people that are going to care, and hopefully they're the exception to the rule. I find in my experience, once you talk to someone or we can actually find them, they're not as uncaring as you think. They just need some motivation to move them to another way of thinking about it. I think I had a guy about 15 years ago, and I'm going to say this in front of Mary, but some of my coworkers thought of him as a monster. Like, he's a horrible human being, he's spreading HIV, he doesn't want to do anything. And I went to great lengths to actually find him. I showed up at his doctor's office visit, and it shocked him that I showed up there, but I actually found him. And he wasn't a monster, and he just needed someone to discuss with him. And I learned the things. He felt like, if he disclosed his HIV status, no one would ever touch him again. There was a lot going on in his head that's like, so, it's a matter of perspective of what motivates people. There are people that are, I'm sure, that could be malicious about this, but I think in general, we're all human, and there are reasons why people are not disclosing or out there having sex, whether it's positive or not. Okay, the data to care element of this is like, what it is like now we have the ability, the laws have sort of like unchained the information to where it can be shared now. So with the basis of HIV, so what it is that we can get the readings of people. We know that someone is HIV positive. There's a full data set of this, and they can keep track to see how long it's been since they had a CD4 count or, a viral load test done. And if it's not been done in a certain amount of time, it triggers a reaction. Before that, these laws were locked in. And what a big change is that the HIV advocacy groups that were preventing a lot of this from happening, they were brought in and sold on this, and they wholeheartedly agreed to the plan, which is another thing that makes it work.
What is the time frame for T-cell count?
14 months.
Viral load, 14?
14 months, yeah. Again, this is the law, I'm not going to read it, but that supports this new information sharing. And like I said, it's information sharing. If it's about the HIV, we can share HIV information from you to us to you, that's based on helping the patient get into care. And this here, just to drive the point home, these are these cascades. So this again, remember that initial slide, 129,000 people, let's say, estimated with HIV infection. Persons living with diagnosed with HIV, 112. So this little gap here was that first thing, that traditional partner services, those people who don't know their HIV status. This is what they estimate the number to be. So there's like, what is it, like about 17,000 people that may not know their HIV status. We need to find them. That's what those other laws, that one opt-out law was about. It was one way to do it. You know, back to the opt-out law just briefly. Remember the syphilis epidemic in the late 80s, early 90s, where it was with crack addiction and prostitutes, et cetera. What they did is they started screening, broad-based screenings and entries into the system, whether it was prison or drug rehab. And that's one of the ways they were able to combat this, because again, these people weren't showing up at the doctor saying, hey, I want a syphilis test. So I think that was the premise as well with the HIV opt-out law. It definitely has its problems when you're talking about, you know, younger people, was the nuance of that, but it actually has it's a good idea in its making. Cases of HIV during the year, we have 86,000. Cases with continual care, 74,000. Virally suppressed, only 70,000. So only 55% of the infected are virally suppressed. We would like to get that number over 90%. And again, like I said, it creates like a herd immunity. That's the way to think about it. And this is for local. And again, like we said, Mary said, if they had a lab within 13 to 20 months, and whether their viral load is detectable or they didn't have the lab, then it goes to New York State surveillance system. A case is generate a case assignment. In our case, it is directly reported to the local health department, and that would be Mary, who's speaking here. And if in other areas our county's big enough to have our own program, other counties are not big enough, so they're regional, so they give it regionally and to the county residents. And then Mary will work on linking them to medical care, make referrals for identify other services, prevention risk reduction counseling, and safer sex supplies. We have all of that stuff. And the thing of it is like one of Mary's key roles is like that person that's stubborn about, like, you know, because over time people with this infection, they're not sick, they feel well, they're thinking, why do I have to take medicine? You know, and one of Mary's jobs is to find out what ways to motivate that person to make this important again to them. You know, it may be that, like, they're homeless or they're having drug abuse problems or other issues that are preventing them from, you know, staying retained in care. The other thing about a lot of these people, the initial hit is that we find out that they either moved to Georgia or they're dead. So it's another, in the beginning, there was a lot of cleaning up of all the data. All these people were assumed to be in New York, so there was a large swath of that as well. And we're also finding that some of them are actually in care still. So the third part is providing access to pre-exposure prophylaxis, or PrEP, for high-risk persons. And we're going to talk in detail about PrEP. What is PrEP? What it is like the drug that they use currently is Truvada, and it is a daily medicine taken to prevent a person from becoming HIV infected. So they're doing risky behavior, but it will significantly reduce their chances of getting HIV. It's not like a vaccine. It's not 100%. We still need to do risk reduction counseling, talk about condoms, talk about safer sex. But a lot of the studies, when I was reviewing the studies, they find that people they know on PrEP are more likely to probably take some of those risk reduction behaviors. And personally for me as a gay man, it's like, this was what actually, I think the first time I heard this, one man said, it's the first time in my life that I could think about sex and not think about death, and I almost would parallel it too with almost like birth control in some ways as well. So it has its controversies. I remember this thing in New York City I went to about it, and the providers were divided on whether they believed in this or not, because a lot of providers felt like, why do I want to give a healthy person these antiretrovirals, and others saw the benefit of it. So I can definitely see, and others felt that like it gives them a license to go out and be risky, and I think that, to go back to you, there are going to be people on both ends of the spectrum. There are going to be those people that are going to say, now I can be a whore and do whatever I want, and then there's other people who are going to take their, be very diligent that this is another thing with condoms to make sure I don't get HIV. But I think most of them fall in the bell curve in the middle, and with a little motivation and stuff, this at least is a tool that we didn't have before to use.
Andy, I just said too that
Sure.
a lot of times when we talk about PrEP and we think about men having sex with men, we found that has a much wider scope. When we have women who are in either the sex trade, women with domestic violence, there are different groups of people that would also benefit from PrEP that aren't just MSM. So we have to think about sometimes when you're talking about it with neighbors or friends, you don't understand who else could be involved. There's a lot of people who are forced into positions that they don't need to take, where a woman could, if she can't make her husband wear a condom and he's not a drug user, then at least she has something to hold on to that she can, from her provider, take a pill every day to reduce her chances.
Yeah.
How does it compare with post-exposure prophylaxis, for people who taking necessary risk, or high risk, but infrequently,
Well, post-PEP or post-exposure prophylaxis, the studies that they've only done studies with it on people after they've had like a needle exposure, and that's really where the main use is around. It's starting to catch on as almost like a morning after pill kind of thing, but the efficacy of that has not been proven yet, from what I've read so far. But it's definitely a movement to add that as well. But again, it's not a guarantee that the person, but it may have some benefit if they can do it in a timely manner. I think by the time people, or what I saw, a lot of times that people wait too long before they think about doing this. And I think the availability, it's not widely available or used for that, but I know it's definitely, right now, PEP is mainly used for, like, someone who, like here, who exposing themselves, they would start on it immediately. But again, as far as like a morning after pill kind of thing, that is not widely done here, but I think it's starting to, they're starting to get a push for that. Yes?
I know, for instance, if I'm doing dental prophylaxis, taking my amoxicillin before a procedure, for instance, it takes an hour for the amoxicillin to get up to reasonable levels before the procedure. Is there a time limit?
There is. You have to, almost like malaria meds as well, for malaria prophylaxis and travel, you have to start the medicine, like, I think like a week or a couple weeks.
It takes a while.
Yes.
Or is that for the post-exposure or pre-exposure?
Pre-exposure.
So for the pre-exposure, depending on whether it's male or female, it can take up to 21 days, or it could be up to 21 days.
But it depending on male or female, it can take up to 21 days to be fully as effective as it can.
Right.
If it's taken properly, it's 5 to 7 days.
Can they get this through the STD?
Well, let me, I'm going to move on because I'm going to talk about that. So, all right, so, okay. So this here, as Mary talked about, high risk is not just MSM, and I'm sorry that, like, I give MSM bias, but a lot of the studies were done with MSM, with PrEP, and that's why they're pushing it. And that, right now, where early syphilis and new HIV diagnosis, that's where we're seeing more of the new infections. But again, like I said, heterosexual women and men of high risk, and also injectable drug users, because we're beginning to see the beginnings of some of these diseases find their way into the heroin population. So like, and that'll be a new round. So then you will start seeing women with this issue. I did it with the OBs last week, and they said that two of the providers said that they would want to become PrEP providers, partly because they have high-risk women who use injectable drugs or have partners that use injectable drugs. Again, who is at high risk? Just to go back to Mary, it said for MSM, these are all the new HIV diagnoses, but high-risk heterosexual sex is still up there as well. So just so you know, it's not just MSM. There are MSM, discordant couples, injectable druggers, high-risk heterosexual sex, and others, I'm sure. And again, yeah.
Discordant couples?
Discordant couples, one is HIV positive, one is HIV negative.
Sorry about that.
Yeah. So again, I'm just to give you some more graphical evidence, male-to-male sexual contact, just to go back to what we were talking about before, this is the population where even though there's 50,000 new cases a year, we're still seeing in some populations it's starting to a significant increase in cases, new cases. And again, this is for, talk about high-risk heterosexual sex. We talked at the beginning about chlamydia. This big bubble here, chlamydia is the most reported communicable disease in the country, and females are just have most of the burden of this infection. Again, so there is high-risk heterosexual sex out there. So again, I try to get away just from an MSM bias and have to think outside the box. A lot of people other than MSM would benefit from Truvada. Okay, and this slide was new, and in 2014 was the first time in a long time in New York State that the three main STDs have all shown an increase as well. So people are taking high-risk sexual activity out there.
You know the data in terms of either chlamydia, gonorrhea, or syphilis, and the risk of having AIDS at the same time?
Well, I don't know the data specifically, but I do know that if they have one of these STDs and they're HIV positive, it significantly increases the risk of transmitting the disease to other people. So, but I know that for syphilis, that 3 out of 4 of the people who have early syphilis, in big cities especially, usually have HIV as well. I have read a study about that. As far as chlamydia, I don't know that the link is as high, but with gonorrhea and syphilis, probably about in that realm. Again, one of the things not enough healthcare providers know about PrEP. 90% of daily PrEP can reduce the risk of sexually acquired HIV by more than 90%, 70% for IDUs. But 1 in 3 primary care doctors and nurses have not even heard about PrEP. And I have Candace here from Hudson River Healthcare, but where can patients get PrEP in Dutchess County? Part of why I'm out here talking is there is a state registry of providers in the county, or in the state, that offer PrEP. But in Dutchess County, and I'm going to hand it over to Candace from Hudson River Healthcare.
Okay. So we provide pre-exposure and post-exposure services within our facilities that we have in Dutchess County. Currently, we are mostly the ones who provide the PrEP here. So part of my job is not only to educate the community about the services that we provide, but to also educate the other providers in the area so that all providers are educated about PrEP, and because any provider can't prescribe PrEP for their patients, and just not enough providers know about it.
Yeah, because if I learned anything, it's like any one of you in this room can be a PrEP provider. And when I did the first talk, one of the internists said to me, he says, for me personally, I would not want to, no offense to Hudson River Healthcare, but I don't want to go somewhere else to get PrEP. I want to get it from my doctor. And my doctor can do it. And the CDC has really, really detailed guidance on how to administer PrEP. It has really very specific protocols. This here was a little diagram of the whole experience, but anybody in this room can be a PrEP provider. Yes.
So the question goes back to the testing. how does that work in relation to health insurance?
That's always an issue, when it comes to adolescents or even, like, for instance, college students who are still on their parents' insurance up until 26, because the parents will obviously get the estimation of benefits. That's still a concern, that's still an issue. As far as providing services, because we are a community-based organization, we are able to waive fees as far as our services, but when it comes to prescriptions, because the Truvada is expensive, they have to go through their for now. I know there is talk about lobbying for passing the law, something that all these working on trying to pass the law so that that's not a barrier.
So a lot of the insurance is covered?
Yes, all insurances do. It's been most things that I've seen thus far is just needing a prior authorization depending on the insurance. Some of the insurances, the private insurances have high copays, but the manufacturer, which is Gilead, has several programs, whether it be, they have, it's called advanced accessing, whether it be for services and medication, and for patients who already have insurance, who have high copays, they have what is called a copay card that usually brings that copay down to zero.
What about, like, Medicaid?
Medicaid usually covers 100%.
And like we said, the Gilead program will also, for those people who can afford, they have programs to help get people to medicine as well.
And then they have the PrEP Act. For those people who are undocumented, as well as the Advanced Access, which is through Gilead, the PrEP Act is through New York State. It's kind of like ADAP, which is the for HIV positive patients, but it's the ADAP for PrEP, which covers the services. And then we kind of use them in conjunction. The PrEP Act will cover services by the provider lab or doctor's visits. The Gilead application for Advanced Access will cover the medication costs.
Do those move through pretty quickly? My concern would be if we send somebody there and it's like, well, we're going to get you a prior auth and we're going to get you through the company. If it doesn't happen immediately, we lose track of that patient very easily.
In my experience, it moves very quickly. Because of the way I have it, if I have a patient that I know ahead of time, number one, if there's somebody, first of all, I'll screen them. If they're in office, I screen them in office. If it's a referral, I'll screen them over the phone. If they don't have insurance, I get their information and I start that application right away. With the New York State, the PrEP Act, they're pretty quick. It's usually within a week we can have time, if that. Advanced Access, which is through Gilead, is about the same. It could be even less than a week. The copay card, which is needed, I'm sorry. The copay card is usually right away. If the patient has private insurance, to say the copay is $300, I call Gilead. It takes about 10 minutes, activate the copay card, call the pharmacy. That's done, and it's good for 2 years.
It's expensive. How expensive is Truvada?
I want to say per month supply is $1,200.
Yeah, that's what I thought, somewhere in about $15,000 a year too.
And the PrEP app, again, the PrEP app and the Gilead, usually if there's a patient who has no insurance, it's usually, as far as I've seen, it's been a very good turnover as far as them being able to get the medication for free. And it's usually up to a year, and then you reapply.
And then not to, like, get off of PrEP, but could you kind of go through, like, something like that about the post-exposure?
So the post-exposure usually comes from the safe unit. They either come from Manhattan, well, technically now Westchester or here, and they're referred to us by the safe unit. So they have already come in either from a consensual unprotected sex or a sexual assault victim, and they usually come to us after they've already been here, and I get them in to see the provider within 48 hours so that their medication is continuous. They've already had lab work, they already have had their rape kit if that's the case, and they come to us for continuation of care.
And what's the time frame that they need to start the prophylaxis?
So they need to start no later than 72 hours.
Same as if you had a post-exposure blood here. So if you just stuck yourself or it's the same thing.
And what medicine is used for that?
So there are 2 medications.
Eminence and Truvada.
Yeah. So it's the Eminence and Truvada that are used together.
So they're both also, is it one time or?
Well, one is, it depends on which one it is. So it's, you can either do, and there's a little, I can actually drop some of these cards off. So there's the tenofovir, which you take with the tenofovir. Those are 1 time a day. But if you do the Retnavir for twice a day, for 28 days.
28 days.
So one pill will be once a day, one will be twice a day, depending on which route you go, because you have two options for the second and the
Together is Truvada.
Yes, that's Truvada is the mixture that's.
So you take 2 pills a day for 28 days, or if you find a person is negative, that you had,
And you have the same kind of coverage or for people that can't afford it, or?
If it's a person who has been, if it's consensual, again, our services can be waived as far as the services we provide in office. If it's, again, the medication part, they're still going to have to use their parents' insurance. If it's a safe unit or sexual assault victim, that's picked up by the state.
everybody knows that safe is here. It's a unit where a person comes in who's been sexually assaulted, men or women, regardless of age. They actually do have a pediatric provider, especially certified. They make them here, they do the exam, they gather the rape kit, they keep all the stuff. They keep everything, but all talking to the police, I can't do the word. And they maintain that so that if the person wants to prosecute, then it's all been documented for them. It's not just out of Bastrop, it's a nice location that they have.
For Mrs. Regional, is there a unit there, or do they have to go to Westchester? How is that working out?
Unfortunately, now, they have to go to Westchester.
Yeah.
And we're working on it, because it's a lot, because you have a really dedicated group of people who are advocates for the victim, and they start immediately with that patient, they're bread and butter for that kind of time, and then they stay with them during the exam, they could go to court with them, they could provide their counseling, and that link is a really strong bond. If they go to Westchester, they get broken out, and sometimes that's a faster spot.
So the safe unit is, they have to go through the ER and then get the first care?
There's a system in place where if someone comes in because they're sexually assaulted, because there's a law that they have to be linked to care. Someone is aware in the ER, but then they have a whole unit that the person is escorted to. And they have to be registered because I don't know the law, the title of it, but they go someplace else, and the nurses are trained. We do the exam and we gather the evidence. And then they go to testify in court. But they would get prep, or say you'd have to stuck with a needle. I mean, it's the same treatment that you would want for that. Truvada is very well tolerated. Stomach upset, that usually goes away within the first 10 days. Yeah.
Do any liver function test, any kidney function test, when you're on Truvada,
Sure. The initial visit, the initial assessment with the provider includes an oral rapid HIV test. It also includes a full workup. It's the CDC comprehensive. It's a hepatitis panel, HIV 1 and 2, RPR.
Yeah, they do the kidney function, they check all that.
Yeah,
and then there's a whole, if you go to the registry, there's a whole set of rules. So that you have to be tested, was it 4 times every 3 months?
Every 3 months.
Every 3 months they get
And you get that screening.
And what I like about it, because of my job, they're also talking about their partners, either getting them tested, coming to clinic to get tested, or them as well to be putting on some sort of pre-exposure program.
Yes.
So this customer health care is covered from the health department?
Right, and you remember that one slide I had where the plan is to have providers, the health department, and CBOs work together, and she's part of the CBO.
They're for the underinsured and uninsured.
Huh? I believe, yes.
Yes.
Yeah.
But the good thing about, what I like about them is when I've been working with them is, say you have someone who has great insurance, and they want to use, and they don't have a PrEP provider. One of the things that I really like is one of their doctors is an infectious disease doctor, so you can see a specialist within, like, say, MVP, and you can choose her just for your Truvada, but yet you'll still maintain your provider, which keeps you in care for your other medicines. But you can go there and just get that branch of their service. You don't have to lose the entire patient as a specialist. You've seen.
We're going to change the primary.
Right, you keep your primary, but you just go to them as a specialist.
I mean, is this something that, what are you seeing in terms of what our patient population would be and this kind of stuff?
Well, for pediatric, I mean, you still, I know that you guys still see, like, especially people over the age of 18 still, number one. That's, not to say that the younger people, there are nuances and issues related to that. But like I said, you definitely see people that are of age and are definitely at high risk. And that's why I thought you guys would benefit from hearing of this. And my other thing is, like, there's not enough options. I mean, Hudson River Healthcare shouldn't be the only option for somebody in Dutchess County. Not to say that they're not great, and I don't mean that, but I would like to expand the options that patients have. If they want this, like I said, for me personally, I wish that I would want my own doctor to do this. You know, not to say, and not all doctors are comfortable with it, not all doctors want to do it, and that's fine. Yes.
Just to reobtain and say,
It's okay.
if you want all of that, but until their money goes where their mouth is, and they say ACO should have all this social work base, but hey, we're not going to fund that because we would still spend $10,000 on a cystoscopy and 10 cents on this. Until their money goes where their mouth is, this is all hot air. It's all hot air. It has nothing to do with reality.
Okay.
And I hope somebody communicates that to them, because they can say primary care needs to do this, and this, but hey, by the way, there's no funding for it.
Again, you're not, number one, you're never, I would just say you're never a pain. I like the things you have to say because it really helps us. I want to say that to everybody in the room. I've been coming here for years. I get it, like I said in the beginning, I get as much from you as I hope that you get from me. It really helps us, you know, we can together, whether it's the CBO, us, and you, we can come up with a solution that works for all the patients, and that's the goal with this. Like, I don't have all the answers, and neither do you, and like maybe together we can come up with something that will work. So I just wanted, my main goal is to make you aware of this, that this is out there and this is happening.
You asked about who we see and how the clinic, what we do at our clinic is we screen every single person who presents. We're not going to come to an STD clinic without present. I know we just take that as a snapshot in time. So we screen everybody that comes into our clinic for PrEP services, and we at least discuss with them to let them know it's out there, because kids talk, kids are on networking. They may not need it, but maybe their friends do. So it's just an avenue to get the word out. Same with your patients may not need it, so sign in your office. Maybe their parents need it. We have a lot of young people, I'm sure you're more aware than I, we've seen an increase of our IVDUs. We've seen an increase of a lot of kids now using anabolic steroids. We see them in clinic. And so they're sharing their at-risk behavior. The amount of people now that are on Tinder, that's now taking you out of the safeness of Dutchess County. You're now hooking up with people from other parts of the country, states. So there are other risks involved just besides what we see. So we're trying to just get the word out there, so even if it puts that little seed in their brain, that there's a safe place they come to, at least get some information. But everybody's discreet. We are.
Another question.
I have a question. Maybe I missed it in the beginning. If I did, I'm sorry for repetition. But for the STD clinic, if you have a suspicion of abuse, what is your policy and what do you do? Because you're trying to promote confidentiality, so how do you move a child from confidentiality going to you to you were raped, we need to?
All right, well, there's two different things. If a person is for sexual assault, then they could be referred to the safe unit. They're much better at transitioning that patient. As far as abuse for our clinic, we don't report it, but what we do is we do a soft hand in hand with the person and try to get them to self-disclose. And most of the time they do.
That means you do what they need to have for evidence, and you hand it over to the police for safekeeping. Is that what you're saying?
If it's a child abuse patient,
yeah,
taking advantage of a child, then we would, if the patient comes to us and says, you know, it's my stepfather, we would screen them, but we would then refer them to state. State, we do a soft handoff. Our building is right next to domestic violence, where the SAFE program starts. They would come over to talk to that patient, and they take that patient from us, and then they would hand over the gathering of the evidence, to get trial information. But if it's a routine kid, routine patient, routine patient come in, then we just screen them and give them the best advice we can on risk reduction, anything from, you know, drugs and alcohol, sexual behaviors, stuff like that. We've seen an increase in the last couple of months about kids being given Rohypnol. Date rape drugs, that's out there.
Yes.
So we try to talk to them about that. Some of them aren't ready to disclose. Some of them you know, are just making choices to have unprotected sex with their partners. A lot of people feel very safe, and they feel that everybody's safe, and that's almost the activity pay on the part of the patient.
When if you send out posters or so forth on HIV testing, if you include information about safe.
Sure. We do the safe, we can do the prep, we can do our clinic hours. Again, it's signage. I mean, these kids are very smart. If you have a poster up, they can read it, they can take a number off it, they can put it into their phone, they can Google us, they can put in STD testing and the county department comes up. These are all ways that they're aware. We just want them to be aware that there's options out there, because, you know, we're talking about infertility later on, we're talking about just the sheer panic of these kids. We have had kids who have been assaulted and now they're suicidal. That's why we're now the Department of Mental Hygiene. So we do a lot of screening in this clinic. And for me, I love this clinic. That if they come back in, it's always the opportunity to change. They get a little bit more information. We can get them to a needle exchange. They're ordering steroids off the, they all want to make varsity football. They're all bulking up. You see your kid now, you know, gain 60 pounds. You know, we want to make sure they get access to clean needles. We want to make sure that, so it's a very comprehensive clinic. So you're our first line provider, so PrEP can even help with the sharing of those needles. And these kids, they're pretty smart.
So, yeah, we definitely will put together packets, and we'll be visiting you to bring the stuff to you. I guess would be the way to go. So, you know, I think, because I like the idea of that. We have the resources.
You have the passion, I think.
And
I think that's what I like.
That's the passion. But we also have the resources as well, so we can get them to you without you having to order them and stuff. So, again, I just want to say thank you to all of you. That I actually love coming here and talking to you about the topic of the day. But like you guys, like I said, you guys help inform us and help us, you know, come up with problems to solve. So we really appreciate it. Yes.
Do you have any stuff on social media that can be downloaded by teenagers?
Yeah, so that's just kind of, I'm sorry, Andrew.
Go ahead.
Now the community services X app, we can get you posters for that. It's 24 hours that these kids can text, and there's Center for Mental Health there. If there's any questions, if they're feeling lonely, and they will then put them into services. It's a text.
Download it through.
It's an app, and you download it to your phone.
Is it the Google Smart?
Yes, it is actually. It's on. I don't know. I think it's called Dutchess County Text. TEXTS. But I will get you posters on that. It's a very nice little green sign. It says, you need, you know, are you out there? That's how I know how to start. If you see somebody type it in, are you out there? And it says, yes, I'm here. How can I help you? So, yeah, we can get you those. It's in the Google store, but.
Good. That's good stuff. Well, thank you.
Thank you.
You're welcome.
That's why I keep running in and out the door. Good. Oh, this is so good. All right.
Stand and stretch a little bit.
There's more, unless you need posters in the back for those people to see that.
Great, good. Thanks, Andy. Sorry I'm late. Hey, it's all right. We're having another meeting.